Good morning, everybody. If we could please have you take your seats. We're going to begin with our second presentation. I think those of you can see me in the exhibit forum room as well. Please come on in to the auditorium if you want to join us. Now's a good time. A couple of housekeeping notes here before we get started. Again, thank you all of you who have filled out the registry forms already and the yellow form for the remote health monitoring study. Please consider doing that throughout the day. I'm around. You can certainly give it to me or any of my volunteers. And again, really want to thank you for that. How's the temperature in the room? Okay, so we've actually called facilities management already, and I can feel it cooling off because I can feel the air coming down here. Particularly at the bottom, and I think it's going to get better up where those of you sitting at higher ground too. But just know that the temperature has been reduced, so that's been taken care of. Other thing too with regards to seating, and I'm sorry I don't want to be a nag about this, but we do have a lot of open seats, particularly down here. So if those of you are willing to move in a little bit, that would be great, just to allow so we have more people can sit down and sit in the seats in the auditorium. That'd be wonderful too. Okay. Why don't we have everyone come sit down? Someone asked me to ask a question of the audience I thought was pretty interesting. How many of you are family members who are attending? Okay, so I'd say more than half. How many of you are professionals attending? Okay. How many of you fall into another category? Okay, good. Thank you. So, yep, very good. That's good. All right. Well, I think we're going to get started here. And I know it's a little bit in transition mode, Amy. I hope you don't mind. But I am so thrilled to have Dr. Amy Busker join us this morning. She's going to be talking and giving a presentation on a topic that comes up over and over and over on a yearly basis in your comments about we need more information on medicines, we need more information on medications, etc. And there's probably no better person to answer those questions, both in a traditional presentation and then also in question and answer than Dr. Amy Busker is. Dr. Busker actually works in she has many roles, but she works in a new clinic that we've started at Fairview. It's called the Memory Care Management Center. And we're so thrilled to have Dr. Busker as part of this memory care clinic. The clinic itself, it's run by an advanced nurse practitioner, Dr. Siobhan McMahon, and then also with Mark Reese. Do all of you remember Mark Reese? He used to be a main kind of coordinator of this conference over the past few years. He's now transitioned into a more full-time clinical role, and he's providing family support and counseling in the clinic. But we were thrilled when Amy came along because one of the things Amy does, we meet with families roughly 90 minutes at a time, which is pretty substantial for a clinic visit, I would say. And what Amy does is she meets with the family and the person with memory loss initially and goes through the medication issues. And I can't tell you how critical and important that is in the context of Alzheimer's and dementia for issues like comorbidities, like we talked about earlier in the morning. So Amy's going to be talking about that as well as some other key issues. So please join me in welcoming Dr. Amy Busker. Thanks so much, Amy. Really appreciate it.
Well, thank you guys for having me. All right, so what I'm going to talk today about is medicines that may complicate thinking. And I'm guessing that a lot of you maybe have some allergy medicines that are sitting around the house, maybe something for dizziness or vertigo, an over-the-counter sleep aid, things like that. And those are among the many, unfortunately, the many products out there that can really complicate thinking, and it can contribute to confusion, sedation, memory impairment, and really worsen symptoms for patients that have memory problems as well. So what we're going to do is we're going to become familiar with what these medicines are that can negatively impact thinking. We're going to review common medication problems seen in people with memory loss. And then we're also going to discuss next steps for improving medication safety and maybe what are some alternatives that we could do. But before we hit at these objectives here, I just wanted to mention a little background information. And as you all are very well aware, our population is aging, and we have a lot of people out there that are 65 or older. And with an aging population, we have increase in chronic illness. You know, he mentioned that in the first talk here as well. But with the risk of chronic illness, it increases rapidly with age, and multiple conditions are common. It is not uncommon to see someone who has memory problems who also maybe has high blood pressure, diabetes, heart failure. It's it's more the norm than to just see someone with one chronic illness. So of course, quality of life is greatly affected. And dementia and Alzheimer's are among the several common disease states in the elderly that we see. So of course, it's no surprise then that we have all these chronic illnesses as we get older, and then we have older adults that are purchasing medications more. And unfortunately, as you get older, your body handles medicines differently. So what may have been safe when you were 30 years old is not necessarily safe when you're 70. And there's your kidneys, and they're not working quite as well as they used to, and there's drugs that are excreted by the kidneys. So these are all things we need to take into account. And so older patients with dementia tolerate drugs even less favorably and are more prone to developing drug-induced cognitive impairment. And so it's really important to know, what you can about those medicines that may contribute to this problem. So the medicines that may negatively impact thinking, the first couple slides here that I'm going to talk about, can I, from a show of hands, maybe see how many of you have heard of the Beers list? Okay, that's good. So what this list is it's a list of potentially inappropriate medicines for patients that are 65 or older. And it's not a hard list of you absolutely have to avoid these medicines. In some cases, they can be appropriate, especially for our hospice patients, for example. But they are red flags for us, for older patients, especially older patients who are more frail and maybe less functional. But it's something we always need to be aware of and to be looking at. And so that's why this Beers list is a helpful tool for knowing what medications may not be safe. So, and again, it's because the safety is because of how our bodies change and drugs are impacted differently or impacting our bodies differently. So, all these meds on the next couple slides are on the Beers list. And the first couple slides, I'm really concentrating on anticholinergic medications. So, and I'm going to talk about that a little bit, but the first class that we see very commonly and is very common culprit of problems with memory or cognition are the antihistamines. And so included in there is diphenhydramine, which is Benadryl, and hydroxyzine. And so these are, as you all, I'm sure, are aware, are commonly used for allergy symptoms, allergic reactions, and the reason why they affect cognition like they do is because of their anticholinergic properties. So drugs that have anticholinergic properties contribute to, like I mentioned before, confusion, foggy thinking, sedation. They can impact memory. They can even cause anxiety, agitation. So there's a lot of not great side effects from these medications, not to mention falls. Falls is a huge one as well. But we're obviously concentrating today on the ones that can impact thinking. So I wanted to mention Benadryl because, again, very common culprit. Also, it's in a lot of combination products out there. So although it's used, for allergies often, I think what I typically will see people using it for is sleep. And so Tylenol PM, the PM in that is the Benadryl portion it's the Benadryl portion of the drug. And so that's what's helping you sleep. The issue with it, too, is it has a really long half-life. So it sticks around in the body for a long time. And so even if you take a dose, what you maybe perceive to be a small dose prior to bed, the next day it really can impact your thinking and cause confusion. So this is one that when I see this in the memory clinic, or honestly, I work with geriatric patients all the time. This is one that gets me excited and I don't want you on it. So that's the first generation antihistamines there. The next class that I see frequently is the tricyclic antidepressants, amitriptyline, which is Elavil, or Doxepin. And these are just, of course, examples. There's many more that fall into this class. But these meds used to be used more for depression or for anxiety. I see them more commonly used now for pain, so maybe nerve pain, for sleep, migraines, amitriptyline, you'll see that used sometimes for migraine prevention. And again, the risk with these are those anticholinergic properties that I mentioned. They have those, so the sedation, the confusion, impairment in memory, all can be impacted. This one comes as a surprise to some people. The H2 receptor antagonists and ranitidine, which is Zantac, and so these are used for reflux or heartburn, and ranitidine is a more, again, anticholinergic one. There's other drugs in the class that are less anticholinergic, so have less risk of complicating thinking, such as Pepcid or famotidine. So that's something to keep in mind. And then we have the GI and the urinary antispasmodics. So dicyclamine is bentyl, and it's used a lot of times for irritable bowel. Oxybutynin and tolterodine. Tolterodine is Detrol. So these are drugs that are used for urinary frequency or incontinence. And they, again, have all the fun side effects that I mentioned. And so it's important with these because they often aren't very effective either. And really working on those non-pharmacological measures before using a drug is important. And then the anticholinergic, anti-Parkinson's agents like benztropine and trihexyphenidyl. A lot of times these may be started earlier on or in a younger patient who is diagnosed with Parkinson's. A lot of times we see Sinemet now or carbidopa-levodopa, but when I see these and when confusion or psychosis or anything like that is an issue, then I'm looking at these first and potentially tapering and getting rid of them. And then we have our muscle relaxants. So crisaprolol is Soma, cyclobenzaprine is Flexeril. Flexeril is the one with the more anticholinergic properties here, but these unfortunately I see prescribed too often in our older adults, and again, in our older adults with dementia, they're more prone to these side effects. So the thing with these two is that the doses that it takes for these particular medications to really work are just too much for older adults to tolerate. So that's another one that is a red flag. And then we have the antiemetics, for nausea, meclizine, promethazine. Meclizine I usually see actually for dizziness or vertigo. And a lot of times when I see it, I can't help, of course, as a pharmacist, but to look at what else are they taking. They've got to, and more often than not, they're on something that could be contributing to dizziness, and then the meclizine was added. So I'm always looking to see, is there a drug that could be causing an adverse effect, and maybe the reason why another drug is prescribed. But this is one where I certainly have seen that happen. Then the antipsychotics, and this is a tricky one. Olanzapine, which is Zyprexa, quetiapine is Seroquel. Olanzapine is our more highly anticholinergic antipsychotic. And it's tricky because we will see people come to us on these drugs for behaviors, and I don't like to use that term, quite honestly, but for maybe anxiety or agitation or any sort of behavior that maybe a patient with memory problems are having. And the problem is that it can really contribute to confusion. Sometimes there are reasons for them that are appropriate, but a lot of times we see a lot of inappropriate prescribing of these drugs. There's a black box warning for them as well. They can increase risk of death in patients with dementia, and so that is important to keep in mind too. And they're a big reason for falls. So falls are always on the back of my mind along with cognition when I'm seeing people. And then the non-benzo receptor agonists like zolpidem or Ambien. This is on the Beers list as well, and it does not matter. It used to be on the Beers list, but it was, beer. It's Beers, Beers. Yep. But it used to be for, they'd say it was okay for a short period of time, and now it's just, we would like you to avoid these altogether. And I'll come back to the opioids here, but the benzos, like the lorazepam, which is Ativan, diazepam is Valium, are ones that are also of huge concern to us. And zolpidem, the non-benzos, have really been found that they can be their side effects are just as bothersome as the benzos are. We used to think, oh, maybe they're a little bit safer. We don't think that anymore. At least I don't. And then we have the opioids. The oxycodone, morphine are examples, and of course, these can affect thinking in our patients, and especially in our patients with memory issues. So this chart, is going to be a little bit redundant here, but I just wanted to share it with you. This is actually from the updated Beers criteria. In 2015, they have a nice chart that shows which drugs have strong anticholinergic properties. And so these are some of the more common ones that we see. And you'll see under the antihistamines, we have the diphenhydramine oral. I know sometimes people will use maybe the cream for any itching. That's not really what I'm concerned about here. I'm more concerned about the oral diphenhydramine. And then you'll see meclizine is on there as well. And then the anti-Parkinson agents we spoke about, and the skeletal muscle relaxants as well. Orphenadrine, the brand name for that is Norflex, and it actually has a chemical structure that is very similar to Benadryl. And that's one that my grandma actually was put on quite a while back, and it really, you saw a difference, and she was very happy to be off of that when she was. And then the antidepressants, the one I wanted to point out, I mentioned some of these already, but the one I really wanted to point out here on this list is the paroxetine, or the Paxil, and that's because that's in a class of drugs, the SSRIs. It's used for depression and anxiety, and it's one of our very highly anticholinergic SSRIs. And so there's newer agents now, such as citalopram, if you've heard of that, or Lexapro, for example, and that do not have as high of anticholinergic properties, and so are much safer for our older adults with memory issues. So I like to point that one out, because when I do see someone that comes to me on that, I have concerns, and I try, first, do we really need to be on it, and is it something we can taper? If it is something that's felt as necessary, can we switch to a safer agent? And then the antipsychotics that I spoke about as well, the olanzapine is on there, as well as some other older antipsychotics as well. And then we have, under the antimuscarinics, the urinary incontinence agents. And so they're pretty much all there. So again, those are ones we really need to watch for. And I should point out too, oxybutynin is now available as a patch over the counter. And so we worry about the same things with it. So it's not something that I would just start, on your own, or it's something always that we should check on, because those side effects can be there for cognition too. And then the antispasmodics and the antiemetics as well. So I wanted to bring this up. I'm moving on to a different class of drugs here, but what about my omeprazole? And the reason I bring this up is because I'm sure many of you have heard of Prilosec, Prevacid, Nexium. You see it on the TV all the time. But this is a class of drugs. They're called proton pump inhibitors, and they're used for reflux or heartburn. They can be used, often people will be started on them if they've had a GI bleed, for example, and so until they're healed. So it's unfortunately another drug, though, that is commonly started and maybe left on forever and ever and ever, it seems like. And there's a lot of people out there on them. So there had been recent media attention around this because there was a study done, and the authors of this study questioned if this class of drugs was associated with an increased risk of dementia. And what they found was that there was, and the results indicated an association between regular use of these drugs, so not as needed use, not occasional use, but regular use of these medications indicated an association. Now I could probably talk about that. I actually just did a journal review on that not that long ago for a group of people, but so I could talk about that for much longer than would probably hold your interest. But there's of course limitations to the study and there's strengths. But what my bottom line, what my takeaway from that was, only use it, if you really need to and for the shortest duration possible. And there's already risks associated for those of you who are maybe, used to seeing these drugs professionally. I mean, we know that they can increase the risk of Clostridium difficile, especially in our older patients. They can reduce bone mineral density and increase risk of fracture, and so on. So there's a lot of concerns already with these drugs. So really what this study said to me was, it's just another reason we need to really question whether a person needs to be on this particular medication. So we talked about the PPIs and some of the highly anticholinergic agents, and I just wanted to touch on delirium. And delirium, this is a simple definition here, but can be a disturbance of attention or cognition that comes on pretty abruptly, so maybe within hours to days. And patients with dementia are predisposed to delirium, and so of course they're even more likely to, if they're taking a drug that can cause somebody without memory problems to have delirium. If that can increase their risk, they're even more at risk. So the ones that I previously mentioned, all those other drugs, those can increase risk of delirium as well. And so I wanted to talk a little bit about some other ones that can increase risk of delirium too. And so anticonvulsants are among them. Gabapentin is Neurontin and Keppra. And so they're used for seizures. Gabapentin I usually see though now, maybe for nerve pain, for osteoarthritis sometimes, and also for mood. I'll see it started for mood. Maybe sometimes people will do that as an alternative to an antipsychotic. It's different reasons, but these are some common ones, as well as corticosteroids used for inflammatory conditions, prednisone, dexamethasone. And then other psychotropic medications like lithium or the serotonin reuptake inhibitors. And these are ones that, of course, can affect the mind, perception, memory. So this, I know, is really hard to see on your sheet, but I wanted to share it because it is there's a lot of great resources, and I've included it at the back of your packet. At the University of Iowa, they have really focused on appropriate prescribing of antipsychotics in patients with dementia, or they're trying to eliminate inappropriate prescribing. So there's a lot of good information, not just about the antipsychotics, but about dementia in general and treatment, non-pharmacological measures, pharmacological measures, and it's a great resource. But this is one of their drug reference cards that they have, and it includes a list of common culprits that we see that can increase risk of delirium and cause problems, in patients with dementia. And so we've talked about a lot of them that are up there. For pain, I'd like to say with the narcotics and the opioids, they, a lot of times if people are on, they're more of an issue if they're on too big of a dose, just too much for them, or if it's been increased too rapidly, that can be an issue. And then with antibiotics is one that you'll see up there that may surprise you. It's tough with them because it's hard to know, is it the infection or is it the antibiotic? I'm sure a lot of you are aware, for example, urinary tract infections. One of the telltale signs, that we can see in older adult patients is confusion. And so is it the antibiotic or is it the infection? But these are just good things to be aware of. And then you'll see on the right side there are all the anticholinergic medications, not all of them, but many of them that we have spoken about, and common ones that can contribute to delirium and confusion, memory impairment. So I don't think there was anything else I wanted to point out on those. All right. So I wanted to share a case with you. As Joe said, I work in a memory clinic with a nurse practitioner and a behavioral family therapist, Mark. And we had a patient who came in to us, and he's 91 years old, and memory changes going on for over 5 years. He had an 8-year history of bipolar, which we thought was interesting, and the nurse practitioner questioned because it seemed it's not typically diagnosed bipolar at that late in life. So we weren't so sure about that, but he presented with increasing confusion, hallucinations, delusions, excessive sleep, and actually during the visit, he nodded off quite a bit when I was with him. He came in with his wife and caregiver, and he would nod off, and when he woke up, he was angry. I think he got angry. I asked a question, and he's not in his normal space, and got upset with his wife too. But then he'd kind of drift off. So, and this wasn't unusual per the his wife and his caregiver. They said that this was pretty common. When he was awake, he would be angry. He was thinking his wife was deserting him. He'd sometimes maybe see another man there. And he accused his wife of having an affair. So some other background on him. He had had several falls in the last year, and when you see his med list, you probably won't be surprised. I don't think you need to be a pharmacist to be able to see that it's an issue. His MOCA, which is the Montreal Cognitive Assessment, was 4, indicating severe cognitive impairment. But how accurate it was, we do think that he had some delirium superimposed on dementia, and that became really clear to the nurse practitioner, when we were there. And he had a very poor attention span. Like I said, he'd kind of drift in and out from awake to not. His level of consciousness fluctuating, cognitive function was worse in the last few months, per their report too. And he had significant polypharmacy. And that's 5 or more medications. And that can be over-the-counter medications, supplements, prescriptions. And this was his list. He's on about 18 medicines. I know, and this is, I would say the average I see is probably 14 to 15 medicines on patients. It's not, unfortunately, this is what I'm used to seeing. So the ones that I have in bold here are the ones that we immediately jumped out at us as being concerning. And so the lamotrigine, he had been placed on for possible bipolar, the risperidone and the citalopram for anxiety, agitation. He was put on the lithium because of bipolar or mood disturbance. The ranitidine, which is the Zantac, for reflux or heartburn. Although when I asked his wife about why he was on that, she said he had never had any complaints ever that she could remember of this. He was put on the Excedrin, believe it or not, because I asked his wife about this as well, and she said, he was falling asleep all the time. He was so tired. And so they decided to put him on Excedrin because there's caffeine in it, and thinking that would wake him up. Well, unfortunately, the caffeine can contribute to increased agitation and anxiety. So, of course he was tired. He's on a boatload of psychotropics here, So, and then he was on fexofenadine too, and that's the Allegra for allergies. His dose was too high for his renal function. So that's something I'm always looking at too when I see patients, is I'm always calculating their kidney function. And a lot of drugs need to be adjusted, their doses, based on kidney function. So, and then he was on, some other supplements and some bowel meds. He was on finasteride for his prostate, the fluticasone nasal spray for allergies, along with that fexofenadine, fish oil, aspirin, Tylenol. But the ones in bold are ones that we were concerned about. So I'm going to show you what we did. And the first one that comes up is not the most important one, but I couldn't get it I don't know why I did that when I was putting this together. So I'll come back to that. So the lithium was the one that jumped out at us the most, because we know that this can really contribute to delirium. And especially, again, we have a patient who has dementia, memory problems, and he's at even more risk. So we did taper and discontinue his lithium. So we didn't stop it immediately. We did a nice taper and got rid of it. We also discontinued the ranitidine, which is the Zantac. Remember, that has anticholinergic properties that can contribute to confusion and memory impairment. We decided to stop that because, as I mentioned too, the wife wasn't even sure why he was on it. Although I had questioned if maybe he was put on it after he was put on the Excedrin because all the aspirin that he was taking, was maybe hurting his stomach. But so we switched to an Pepsid as needed. We wanted to have something there as needed in case, because he was in an assisted living too, so we needed to put something there in case he had any potential rebound symptoms. And then we reduced the fexofenadine, like I mentioned. He was on 180 milligrams, which was too high for his kidney function, which is actually probably too high for most people that are most older adults. So we reduced the dose of that and changed that to as needed as well, because he was also on the nasal spray. So we wanted to see, could we get by with one drug instead of two, especially when you note his med list. We wanted to simplify things. We discontinued the Excedrin, of course. And then we also switched the risperidone to the quetiapine. And the reason why we did that is because the NP was questioning, was there maybe some Lewy body dementia? And so if there was, quetiapine is a safer option than risperidone. And our goal was to hopefully, taper and come off of the quetiapine at some point. I should mention too, in this case, we were able to do more than one change at a time just because of the nature of some of those changes. But it is, especially when you're working with medicines that can affect our mind, to do one thing at a time is a good way to do it, because otherwise we don't know what's what, So that's something to keep in mind as well. But this was a wonderful, I'm so glad that I was able to be part of taking care of this patient. He is back to baseline. His wife was she hugged us all, when we saw her a few months later. He still has dementia, but he was just doing so much better, much more mentally healthy than he was when we saw him the first time. So. And he's just one of several examples, but so that, that's why it's so important to keep an eye on those med lists. So we're going to talk about some common medication problems that we see in patients with memory loss. And multiple medications are common, and we talked about why that is. And I already talked a little bit about this, the prescribing cascade. And the patient we just saw, the perfect example was he was on lamotrigine, he was on lithium, he was on all these drugs that could be contributing to him being tired, and then Excedrin was started to treat that side effect. And then, the Excedrin with the caffeine maybe resulted, because it can cause anxiety and agitation, that could potentially result in another drug being added. And the example I have here is one that I will commonly see too, is someone's maybe on diphenhydramine or Benadryl, they're confused, and donepezil gets started maybe by their primary or, whoever they see, and then they have difficulty sleeping, so then another drug is added. So this is just a couple examples of the prescribing cascade, and unfortunately, again, is very, very common. I actually went and saw, so one of the other things I do is I go out to different assisted livings and I see patients. All my patients are older adults. I go to assisted livings, and I also go and do home visits sometimes with case managers that I work with. And we went and saw a lady in her 80s who had not performed well on cognitive assessment. And so, she was on multiple meds, more than he was. And I went out and saw her, and, we get out all the drugs, and there were a lot of them, a lot of issues there. But I asked her if I could look in her cupboards, and I was glad I did, because I opened those cupboards, and Benadryl could have fallen all over me. She loved her Benadryl for sleep, and we got her off of it, and we still have a lot of work to do with her, but she's doing better. And so it's really, I cannot stress enough the importance of making sure those medicines are only what they really need to be, lowest effective doses, and that they're safe. So, and again, polypharmacy increases the risk of how we've already seen adverse reactions. Oh, did I hit something? I don't know. Where's Joe? I want the slides.
It's going to take a minute for it to power back up,
Okay.
so just be patient.
I'll try. What was that? Oh, he is. That's a good question. You know, there's actually been new guidelines too that have come out, but they really do recommend the non-pharmacological measures. And the one thing, if that fails for people, what a lot of times I will suggest is melatonin. And it can really work for some. And there's room, you know, we usually will start out at 3 milligrams and we can go up. I think the highest I've really gone up on it is, I've gone as far as 12, but I think typically you don't see it more than 10. So.
That's safe for long-term use?
The melatonin, yeah. Yep. Donepezil can. It can really affect sleep. So that's something when we start people on, we always are following up, of course, to see if they're having any side effects. So sleep issues can be a big one. It can sometimes cause some weird dreams. And what we'll do if they're really wanting to stick with the drug is we'll switch it to the morning time. Because, you know, it's typically started out in the evening at bedtime. But we'll switch it to the morning and that can help. All right, we're back here. So, so adverse reactions, of course, are increased the more meds someone is on, as well as toxicity. Non-compliance, of course, taking 18 drugs versus 4 is a lot tougher. And drug-drug interactions, and this is something I didn't mention with the patient, but he had a few drug-drug interactions as well, because that lithium really interacts with a lot. It interacted with his risperidone, and it interacted with his citalopram as well. And meaning that in the interaction was that it could make things worse, his confusion worse. And then drug disease interactions. An example of that too is, you know, for example, someone taking Benadryl who has memory problems. That's a drug disease interaction because it can worsen the disease. And then we talked about this a little bit already. Increased sensitivity to side effects is a common medication problem seen. Difficulty adhering to drug regimens. You know, for those who are still administering their drugs themselves, that this can be tough, you know, when you have memory problems. And so family and caregivers it's really important to have help there. And then decreased ability to recognize and report adverse events. Of course, you know, let's say we start that person on donepezil and they have a hard time maybe verbalizing, you know, what side effects they may be experiencing. If they're having stomach upset, tough time sleeping. The tough time sleeping you may catch on to, but it's harder to be able to recognize and report those. And then clinical practice guidelines being tightly adhered to. And this is something that I see in a lot of our older adults. And when I see someone in the memory clinic, I'm not just looking to see, you know, what meds are you on that could potentially be contributing to confusion. I'm also looking at everything, because everything impacts how the patient is doing mentally, really. You know, if their blood pressure is too low and, you know, their tissues and organs aren't being perfused as well, and that could, of course, affect thinking. If their blood sugars are too low, you know, that can contribute to confusion. And I'm a rule follower, so it's really hard when it's hard to get used to. This was hard for me to get used to going into geriatrics, you know, as I had been a pharmacist, you know, for years before too, and you're looking at all those guidelines for that patient who's on heart failure or who has heart failure and has diabetes and is on all the medications, you know, because easily a bunch can be added, you know, for each condition. And then you find yourself over treating sometimes. We really have to keep in mind that our older adults are more at risk for side effects, more at risk for falls, and we don't want things to be too tightly controlled either. We have to find that balance. So another common one we see is the use of antipsychotics for behavioral symptoms of dementia. I alluded to this a little bit already. And again, there's a lot of inappropriate reasons we see people on them, and sometimes appropriate. And I talked a little bit about the risks of them too, so I won't get too much more into them, but it is one that we see frequently, because sometimes the patients that we get at the clinic too, they've already been started on an antipsychotic because of issues of anxiety or agitation or certain things that have been going on at home already. And then the other one I see too a lot is use of the high-risk medicines that I mentioned. We see a lot of benzos, for anxiety, for sleep. And so those are, of course, your lorazepam, Ativan, clonazepam, which is Klonopin, and then the Zolpidem for sleep, and Benadryl, like I mentioned too. And Benadryl, of course, it's over the counter, so it's really easy for people to get their hands on. And I think sometimes people think it's over the counter, that it maybe doesn't, it's safe, but it's not true. We need to pay attention, and that brings me into the next two, is the use of over-the-counters or supplements in hopes of improving memory or cognition. So we've seen some people who have come to us on Prevagen, for example, if you've heard of that one. And there's nothing to support that this is helpful, and it actually can be harmful. We know that it can increase risk of stroke, for example. So I don't typically recommend supplements like that. I do recommend vitamin D a lot, but that's a supplement that I do recommend quite a bit, because I think a lot of us are low in vitamin D, and there has been some association with low vitamin D levels and cognition, as well as the bone health and fall and fracture prevention benefits as well. So you've probably figured out my philosophy by now, is that our older adult patients really should be on only those medications that they really need to be at the lowest effective doses, and then improving function and quality of life without negatively impacting cognition is key. So with that, what can we do to improve medication safety? We've heard about all the issues that can happen. And attempting non-pharmacological measures, which we got a chance to talk about a little bit already, but, so for example, good sleep hygiene, and it's tough. I think sometimes this can be really hard, but, avoiding the napping during the day, avoiding caffeine after a certain time, avoiding electronics, TV, whatever, right before bed. For urinary incontinence, regular toileting every couple hours, even if you don't really need to go, and Kegel exercises. These things are important versus starting a pill. And so reducing polypharmacy is key, of course, in improving med safety, because we've seen all the harms that can come from that. And so simplifying the medication regimen, ensuring lowest effective doses. So for example, too, that urinary incontinence or frequency somebody is having, it might be the result of their Lasix, their water pill that they're taking. And they may need that water pill. And so, but, looking at are they on the lowest effective dose? So, and then careful tapering is important too. If first of all, I hope I haven't scared anyone or anything like that. I know that, sometimes I've done talks to groups to patients too at assisted livings, and, they hear these drugs that are considered high risk and they're on them. And I just, of course, wouldn't want anyone just stopping anything without talking to their, doctor or pharmacist. But careful tapering is important, especially for medicines that can impact the mind. So how do we do this? This is my approach to reducing polypharmacy. Is the medication indicated? So is it there for a reason? So with our patient, was that ranitidine there for a reason? It didn't really sound like it. It might have been added later after another drug, which exacerbated things, but asking that question. And if it's not indicated, then it's a good time to think about, do we really need this? Can we get rid of it? Is it effective? So is it doing what it's supposed to be doing? The Excedrin wasn't, and it was actually causing more harm than good, and occurrence of side effects, so we want to look for that too. And if we're seeing that, can the dose be reduced? Can it be switched to something else that's safer? We want to look again to see if there's any drug-drug or drug-disease interactions, and we need to address those if there are. Is the medication at the lowest effective dose? And then is it duplicating another therapy? So in our patient's example, he was on the Flonase and the Allegra. He was on 2 medications for one condition, and they work differently. So it's not uncommon to see them together, but in his case, we really felt that simplifying his med list was going to be the best for him. So we were able to change that. And then can a safer alternative be initiated? One thing I want to mention is there was a study done that looked at patients who had dementia and they were on antipsychotics. And we found that when scheduled Tylenol was added, because as we mentioned, sometimes they can't verbalize, if they're in pain, for example, we found that when scheduled Tylenol was added, there was less use of the antipsychotics. And that would be, that's something we've done for a few of our patients in the clinic too. And it has helped. It has made a difference. And we were able to get somebody off of Zyprexa recently. And we adjusted, and I think there were other factors too, but we saw a difference with adding that scheduled Tylenol. And then is the regimen allowing for compliance? So, a lot of patients maybe are in assisted living, and so they have someone giving them their meds. But if you're at home and you're trying to manage all these medications, we want to make sure that it's the easiest. It's easy for you to fit into your lifestyle, and it allowing you to be able to take things correctly and at the right time and at the right dose. And then is there a more cost-effective alternative available too? It's something we always look at is. And I think with our patient, we certainly help reduce costs with cutting down his med list. It's always a nice bonus. But as I mentioned before, always consult a doctor or pharmacist before making any changes. And then, attempting discontinuation or gradual taper when it's appropriate, especially with the high-risk medications, is important in reducing polypharmacy. So I wanted to share this too. This is also, this is actually a kind of a supplement to the Beers list. And with the Beers list, there's a list of medications that are just considered potentially inappropriate no matter what, 65 or older. But there's also a list of, drug, disease, where in this case, drugs should be avoided because of a disease state that they have. And so in patients with dementia, they have on the supplement, they have offered suggestions that would be safer for people with dementia. So for the tricyclics, if they're taking the Elavil, the amitriptyline, nortriptyline, whatever it may be for depression, SSRIs, maybe bupropion, something like that may be a safer choice. I wouldn't choose Paxil, remember. And then for nerve pain, because we see them used a lot for that. I actually sometimes it has lidocaine patch on here, which is pretty expensive, but sometimes lidocaine gel can be really helpful for nerve pain too, and is more cost effective. And then for the antipsychotics, you can see here for behavioral complications, if non-pharmacological measures have not been helpful, and if the patient is a risk to themselves or others, or if they do have hallucinations and there's an appropriate reason to start them, they've listed some choices here. You'll see quetiapine or Seroquel is on there. It does have some anticholinergic properties, as I mentioned before, not as much as the Zyprexa or the Olanzapine. Risperidone is one we commonly see too, and that's because, for the anxiety, agitation. But these are not FDA approved to be used for behavioral symptoms of dementia. And then the H2 blockers, so I don't really agree with this one, but they put the proton pump inhibitors on there, and what I normally do if I see an H2 blocker, so remember that's our ranitidine or Zantac for reflux or heartburn, I usually try and switch to a less anticholinergic one, such as the famotidine or Pepcid. And I also try and see, do we really need it, in the first place? And then the anticholinergics for allergies, we talked about that quite a bit, but the first generation antihistamines, so the hydroxyzine, diphenhydramine, want to avoid. What could we use instead? Well, we could use second generation such as loratadine or Claritin. That actually used to be on the beers list, but they took it off. And then Allegra is actually a safe one as well, but again, we need to pay attention to dosing. And for Parkinson's, I mentioned too before, you do something like Sinemet versus the trihexyphenidyl or the anticholinergic Parkinson's drugs. For benzos, for anxiety, there's some options listed. A lot of times what we'll do is if somebody comes to us on lorazepam or clonazepam, for example, we will try and switch them to an SSRI such as citalopram. And for sleep, we talked about already. The appendix that they mention here really talks about those non-pharmacological measures. And I know we talked about melatonin as one that I'll recommend if the non-pharmacological measures aren't working. So just some general tips and tricks. I'm seeing how as we're wrapping up here, but these are just things that I think patients and family members should ask themselves. Why am I on this? Because I think unfortunately you get started on something and sometimes you forget why you were started on it, and it must be helping, or I don't think I'm having any side effects, but I think it's important to know that it could be causing more harm than good. And how do I know if it's working? Is it safe for me? Does it fit with my lifestyle? Is it allowing me to be compliant, take them on when I should, and so on? And then keeping an up-to-date list of current meds, and again, including those over-the-counter and supplements. Like the patient that I went and saw at her home who really didn't think the Benadryl was important to share with me was hugely important. So it's just really important to make sure that all things that your provider knows everything that you're on. And the other thing, using the same pharmacy, which is on the bottom there. But I think that's important because, they have, you're going to the same pharmacy, they have your list of medications that you're taking, and they're able to check interactions. If you are wanting to start something over the counter, they can look and make sure that it's going to fit with what you're already on, that there's no interactions. So that's important. Again, asking doctor or pharmacist before starting any new prescriptions, herbals, or over-the-counters, and before stopping too. Because again, it can be really important as well to taper off of a medication to avoid any withdrawal side effects, for example. Or, even with blood pressure medications, it's important because you don't want things to jump up. So throwing away old medicines, never mixing medicines in a bottle, you see that, believe it or not. Using a pill box or any reminders that are helpful for taking your medications at the right time. And I've included some useful resources here as well. And the Iowa one is the second one there. That's the one that had the drug sheet with that can contribute to delirium. Any questions? Yeah. He was up there.
Thank you. So my mother was recently changed from atorvastatin to Crestor because of concerns over it maybe exacerbating her dementia. Do you know anything about that?
Well, there's mixed things out there as far as the statins contributing. I haven't seen it be an issue myself, but I know there are reports out there that it can contribute to confusion. So I think, everybody's different. So if you start taking medication, you think it's causing confusion, you should be able to stop that and notice a difference with stopping it. And so I'm sure the thought here was that trying a different statin would maybe be beneficial. They sure want her to stay on the statin.
Have you heard anything about like maybe any other like cardiac medications that might have any effect on, confusion and delirium and stuff?
Well, I think a lot of them can, just because they can affect blood pressure, and so if blood pressure is too low, for example, there's a lot of debate over what is the right blood pressure too. So usually what we're shooting for, depending on the functioning of the patient, is less than 150/90, because we're really trying to avoid falls and so on. And so we adjust blood pressure medications if we need to. I work with the primary in this case. The nurse practitioner I work with doesn't make those changes, but yeah, there's a lot of cardiac, a bunch out there that can, just because of the side effect profile and the risk of hypotension and tissue hypoperfusion.
Great, thanks.
Yeah. Yes, there's a few in here. I don't know.
I have the,
Where is she? Oh, it's you. That's my aunt.
so I happen to be a clinic LPN, and I'm in a small community that doesn't have the benefit of having a Pharm.D on staff, but I'm also a caregiver. And one of the things that frustrates, or that we run into a lot as a clinic nurse is, first of all, asking caregivers to please come with your loved one to the appointment and know what's in their medicine cabinet, and also just to please review the med list when it's handed to you, because so often it's just, oh yeah, it's all the same. And then we find out a few months later that they're on something that, gee, we had no idea that they'd been taking that. So,
Right.
So just a thought and comment.
Right, and we actually, ideally, bring the medicines with you. Bring anything at home that you're taking. I would love to see those bottles. Over the counter, prescription, I may be weird, I don't know, but it is really helpful for us to know, and bringing them along is really good. Yeah, there's a few in here too. There's a lot in there.
Hi, you had mentioned gabapentin as one of the things that causes problems, but then you also used it as an alternative to something else.
Yep. So gabapentin, it can contribute to delirium or confusion, but so I think the option where they were saying to use it for something else is for nerve pain. So a lot of times, it used to be you'd see more tricyclics, the antidepressants for amitriptyline, for example, or Elavil. Gabapentin is a safer option. Now, that doesn't mean that it can't contribute to confusion, but so it's really important if you do use it to start really low. So what we'll usually do is maybe start with 100 milligrams nightly and slowly taper.
Well,
So
my her neurologist for the neuropathy has her on 800 milligrams of gabapentin a day, and if that's not enough, to take her oxycodone, and she's just not there mentally.
yeah.
What are the options there?
Well, that's where we need to look and see what are all the options that have been tried. Where we need to look and see, everything, what else has been tried. I'd need to know more history. But I think my grandma was on gabapentin as well as on methadone, so you have to balance, because you do need to, and I wanted to hit on this, so I'm glad you asked. It's important to balance that. Pain control is important, So if it's not effective, then I think we need to look at what other options, because then why are we taking it? Yeah, I think a lot of times, unfortunately, other drugs get added then, and it is a struggle. And that's where I think, too, as our first speaker was saying, is where you really have to be that champion, where you can question, and ask and say, I don't see the benefit of this, maybe, and what are our other options? But I think that's where you really have to hold your own and be ready to challenge them.
I want to thank everyone for the wonderful questions and comments. Please, even if you are making follow-up comments, try to say them in the mic, otherwise the recording doesn't capture them. So please do that. And it's important, too, to get the context for when Amy says something, what she's answering. So that would be great. Thank you. Right over here was next, I believe.
The only thing I heard you possibly recommend for insomnia was melatonin. Okay. So the first question is there anything else? And the second question would be, if you are taking melatonin, I've heard discrepancies as far as recommendation of the different times, when to give it, right before bed, late afternoon, early evening.
Right.
So what is your recommendation?
So for melatonin, I usually tell people to take it about 30 to 45 minutes before bedtime. That seems to be what works best. As far as other options, so if non-pharmacological measures have failed and melatonin doesn't do it, I think you always need to look at the other medications. Are there any medications that could be contributing to issues with sleep? So for example, that donepezil, could we switch that? So you really need to look at that list, and because it's very frequent, where maybe someone's on Effexor, for example, that could be contributing to their sleep. Effexor is one that can contribute. There's lots of things out there, lots of other medicines. So looking to see, are any other medicines contributing to issues with sleeping before adding a drug, even before the melatonin. But if you've exhausted all that and there's just still a tough time sleeping, using the non-pharmacological measures, there's the cognitive behavioral therapy and stuff like that, and that is recommended. But as far as drugs go, I guess the one that we will commonly use the most is trazodone. Low doses, we'll use that. We find that that can work well.
What is the low dose?
25 milligrams. Yep. And we'll usually try and do it only if needed. Sometimes if, depression or anxiety are an issue, and that's something we need to address as well. Maybe Remeron or mirtazapine can be helpful for sleep. It depends on what's going on with the patient. Yeah.
My husband was diagnosed with Parkinson's 5 years ago, and then Lewy body dementia about a year later. So my concern is the amount of drugs he has to take for those two things.
Yeah.
And now he's in, two psychiatrists have said he had an outburst at one home, so he was sent to the ER and spent 10 days on the geriatric psych ward, and then we found a good place for him. But now they've talked about lowering dosages of some of those, and I don't know whether I should agree or not. They're kind of trying to take away a lot of things, which is good.
Yeah.
But how do I know? And do we still treat Parkinson's? He doesn't.
Right.
He can't walk, and he really can't communicate. So they started giving him Tylenol, and I thought he has never had pain that I knew of, and unless they're getting some secret answer from him.
Yeah.
Why are they giving him Tylenol?
Well, and I'm sorry, first of all.
No problem. Thank you. I mean,
Yeah.
he's on Seroquel, Cinnamate, of course, finasteride, also a prostate issue. So does that have to be continued at this point? And Exelon. And then do I worry about the things he used to take at home? A multivitamin, lutein, fish oil, a baby aspirin. I mean, should we just leave those alone? It's all.
I think the most pressing issue is if he's having side effects from the Parkinson's meds. I think I would, it's hard. That is one of the hardest, I think, most complicated disease states to work with, and the medications. It's finding the right balance between side effects and efficacy. And so it probably, from what you're telling me, it does make sense to look at adjusting medications. But again, I think that it's important to do it one at a time, so you know what is going on and what's helping and what's not.
I guess I'm not sure which thing to treat question treating most.
Right.
But I'm the dementia for sure is Parkinson's is sort of a low concern at this point.
Yeah, so. And I think those are all things answers you have to come up with yourself, your husband, your family, your providers, work together as a team to figure out the best. Yeah.
Thanks a lot.
Yeah, you're welcome.
My question is similar to the one that was just asked. I'm right in front of you.
Okay, thank you. I'm like, where are you?
It feels like you have to be a pharmacist to know how to work all of these drugs. My husband is in the late stages of dementia, and 3 of the drugs that you listed as the VIR is on the VIR list, he's also on. Mm-hmm. And I am right now feeling at a loss as to how do I know what is the best drugs, because I don't know anything about these drugs, and what is best for him. He's having half of the side effects that you've mentioned,
Right.
based on these drugs.
Yeah, and I think that's where, you can, because we're not all pharmacists, and you just learn what you can and use the resources that are provided to you here today and at the end of this presentation too. And now you know some of the concerns that you have with those medications, and bring that back to the provider and the family and so on, and try and figure out what the best course of action is going to be for him. I mean, I think you can only look at there's Beers List information to look at for, for the community, and that can be helpful. Just taking what you've learned and what you know, and asking those questions. But I think it's hard to wade through it all, and that's where I think it's really, if you can talk to your pharmacist, and I'm going to be here all day too, so please, I'm happy to answer questions. So you can track me down.
If swallowing becomes an issue, is there anything besides vitamin D that shouldn't be either crushed up or somehow liquefied, or?
There's a lot of medicines that can't be chewed or crushed, or so that's information that's out there too. I mean, I have great lists for that, and that's stuff I can send to people if I get emails as well. I'm happy to do that. I think there's going to be a lot of questions. That's a good idea.
Send them to me and I'll post them.
Okay.
I'll post them on the library.
Okay.
So you can access them.
Yep.
My dad seems to wake up with these kind of crazy dreams, is what we assumed crazy dreams, and then kind of gets oriented to what's really going on. Do you really think that would be more delirium than sleep?
I see. I would, of course, my mind immediately goes to what is he on? Right? What is he on? Is he on something that could be causing him to have these crazy dreams? Mm-hmm. I think that would be where I would start, because it could be.
So I just want to, I'm over here, sorry.
Where's over here? Okay.
That sounds awkward, I'm over here. First of all, everybody who's caregiving in this room, thank you, and your family member is lucky to have you. I have a lot of clients as a social worker who don't have family. They don't have anybody. So I do a lot of medication machines, or trying to have somebody call and remind them to take their meds. Do you have any suggestions for people who are really isolated and are having some memory and cognition issues with remembering to take their medications?
I think the medication machine is probably one of the best. So, I mean, to add to that, I think anything that can help with reminding. Some people use, I think there's a lot of different phone apps, quite honestly, now, but you've got to be able to use them is the key. And so I haven't checked those out myself, but yeah, someone would have to set that stuff up for them. But I think the medication dispensing is the best. That's because that gets really tricky. And then, of course, making sure that they're on only what they really need to be on. Things simplified, because that can help a lot.
I have a question about long-term use over here.
Oh gosh, why is this so hard for me?
Yeah. Long-term use. Our mother went through 3 hip surgeries. She was on hydro and oxy 24 hours a day for a long period of time. Can that have a permanent effect on the brain? Or once you leave some of these medications, can you come back to some sort of baseline?
Yeah, I think that usually once you come off of them, that you should, it may take a little bit of time depending on what it is, but should come back to some baseline.
Hi.
Okay, where are you?
I'm over here. Sorry.
Thank you. I'm going to need people to wave their hands. It's hard for me.
My mother-in-law was diagnosed with Alzheimer's about 10 years ago, and she's sort of in the end stages now of Alzheimer's. And we were considering, she's on Aricept and Namenda, And I think the only other meds she's really on are Remeron. She takes Tylenol 4 times a day, multivitamin. Thinking of discontinuing the Aricept and the Namenda, and I just want to know what your thoughts are about that. We've heard some conflicting.
Yeah. So I think that, so Aricept is at the doses that we typically use, the 23 milligrams can be used in severe dementia, but the lower doses are for mild to moderate. I think that a good time to start questioning whether it makes sense to continue these drugs is when you notice the progression of the disease. So a lot of times I do recommend in patients with end-stage dementia, if I see them on Aricept, for example, tapering and getting rid of it. I think that would be a good place to start. And again, I usually will only do one at a time, but I would start with the Aricept in that case versus the Namenda. So I think it's just, once you're realizing that progression is, because they're slowing the progression.
I have a question here.
Okay, yes.
How do you get someone to take their prescription medication every day when you hand them to him? And he'll say, well, what are these? Why do I have to take these? And then we explain these are the prescription medications that your doctor has prescribed. And then sometimes he says, well, what does he know?
Can you hide them in food? I hate to say it, but can you hide them in something they want to eat? Yep. That would be what I...
Over here.
Yeah, over where? Yeah, there you are.
Hi. Those charts look very helpful as far as drugs that could cause an issue. Do any of them have a website that you enter the drug and it pops up that it's a potential problem?
I don't know. That is a good question. I don't know if the American Geriatric Society may. I don't know. I could find out, but I guess that's not a tool I've myself.
But as a layperson, non-medical,
yeah,
it'd be
yep.
It'd be helpful.
Yeah, I know. I mean, if you go to the American Geriatric Society website, they do have the beers list, for example, so it has that list. I don't know if there's a tool on there. I can play around with it and see, and that's something else I can email to you.
Amy?
Yeah.
You've got just a wealth of knowledge, and everybody here is very lucky to listen to you today with huge sincerity.
That's very nice.
One of the areas that I didn't hear you talk about, and it's related around essential oils. And there's a study that I participated in supporting through Health Partners, and it was a small study. We only had a rigor less than 30 people. But we were able to find about an additional 43 minutes of additional sleep at night. And we're getting ready to kind of launch the next study, which will be closer to about 100 people, and looking at sleep. And particularly probably it will be either with lavender or something else. I just wanted your opinion from your kind of pharmacologic brain, how you think about sleep and oils.
I think that they can be really helpful for some people. I really do. And so I think that's a good thing. I'm glad you bring that up because that is something that is worthwhile to try. Absolutely. And lavender, I think, is the biggest one. And I think anything for relaxation is good, whether it is calm music, whatever it may be. But thank you. That is I'm glad you brought that up because I do think that those can be beneficial.
You mentioned a resource about crushing medications, and could you send that maybe by email that we could receive that, or what a resource would be about that?
Yeah, I'll send it to Joe, and he said he can do that. So I think that is a helpful thing to know. There's a do not crush list out there.
A couple of things. Melatonin, if you get too much melatonin, does that disrupt the serotonin? I have a few more comments, if you could take them. Another thing for sleep, if you get a warm bed, flannel sheets, and you tuck things around, cover their head, and it makes all the difference in the world for many patients. If they're in a facility or at home, make sure that they're sleeping on warm sheets and not cool polyester sheets. I found that to be a big help. And with my husband, if he feels chilled or uncomfortable, can't sleep, I just drape a Turkish towel around his head, and that seems to help too. And then I want to tell you about, it was recommended to me for hibiscus tea, helps pain. And then, what do you call the needle? What do you call the needle thing?
Acupuncture?
Acupuncture has been helpful. And then the last thing, Abilify. If you can comment, Abilify versus quetiapine, that would be helpful for me. So, and then the last item, if you can help me remember all these, anesthetics. My husband had a lot of surgeries. Would all the things that prepare him for surgery actually contribute to some of the behavior problems that he has had and dementia and so on? I'm done.
I would think so. I would think that could.
Okay, so I started with the melatonin.
Yeah, and about too much affecting serotonin. I have not ever heard of that as being an issue. I don't know, has anyone in the audience ever heard of that? I've not heard of that being a problem. I think every once in a while I'll run into, I do know a few who have tried melatonin and they've maybe had some very funny dreams or what they call hallucinations. I don't know if they really were, but, and this actually was not a patient at all, just someone I work with. But I don't know of it impacting serotonin.
I just have a comment on essential oils. I'm here at the top. We used it on my mom at end stage, and it was a blessing. It works, and I was using it myself when I wasn't caregiving for her to help me sleep at home at night. So it's fabulous.
Yeah, that's good to know and hear.
No, lavender oil.
That question I had about quetiapine versus Abilify.
You know, I see quetiapine more than I do see Abilify. Same class of drugs. The one thing I've noticed with Abilify, I guess, is that it can contribute more to urinary incontinence than some of the others. So that's something that I worry about with that one, I guess. And I think it depends on who you talk to as far as the efficacy of it. But it's not one I see very often, fortunately. And I think the quetiapine just tends to be used more. But again, there's concerns with both of them. Absolutely, with all of them in that drug class.
You talked a little bit about the antipsychotics and appropriate and inappropriate use. Could you talk a little bit about caregiver safety, whether it's professional caregivers or at-home caregivers, and when it's appropriate and what type of medication for behaviors that may be more violent to prevent injuries to the caregivers, and when it would be appropriate?
Yeah, and so that is one. I mean, so again, if non-pharmacological measures have failed and the patient is putting you at risk as a caregiver, or themselves or a family member, then that would be a case where it would be appropriate to use an antipsychotic. The one that I guess I see most frequently used would be risperidone, and I think that's because of some evidence that with agitation and anxiety that it can be a little bit more helpful versus some of the others. You know, the Seroquel is just so sedating, and unfortunately we see that prescribed now for people just for sleep, and it's not appropriate. But I do think it is appropriate when you are concerned for your safety because of, of violent outbursts. I think that is appropriate. But again, if something is started, really needing to start at a low dose, and titrating slowly. And looking again, are there any other I mean, I can't stress that enough. Looking at that med list again to see, is there anything that could be contributing to whatever behaviors you may be seeing?
Could you comment on the issue of the use of a lot of services that come to long-term care facilities with nurse practitioners and a doctor supervising? Do you see a lot of medications prescribed really by the nurse practitioner? And any comments about working with that system or suggestions?
Yeah, I work with a large group of nurse practitioners who provide services in the long-term care facilities, and the nurse practitioners that I work with they're obviously used to working with geriatrics, and so I think that's something that's important too. When we're thinking about bringing our older adult loved ones for care, is using a geriatrician or someone who's used to working with the geriatric population, and where those concerns, are always at one of the first things we think about, is really important. And I'm not saying that family practice or internal medicine or anything is not good at that. I just think that when you're working with someone who is used to working with geriatrics, who's a geriatrician, who has that expertise, I think that can be really beneficial. And so, yes, the nurse practitioners that I work with out in long-term care facilities are fantastic at identifying things that could be problems.
Can you address the importance of having enough fluids, and how, if you don't, how that affects, especially when people are on 12, 14 different type of medications. Even when the person doesn't even seem to drink that much, but they still are going to the bathroom, and they may not even be going that much,
Right.
but in their head they feel like they need to go. But how much should we stress that the importance of drinking enough water?
I mean, it's of course important to avoid dehydration, so that's key, and we do stress that. But you do need to be careful too with other comorbidities, such as heart failure and so on. So it's again that balance. But we do talk about not only fluids, but just proper diet and stuff like that too. It's being important because it can affect the mind.
Okay. Thank you so much, Dr. Busker. That was an incredible, wonderful presentation, a lot of useful information. Amy's going to be around all day, so if you have additional questions, certainly pertinent to your own situation, please ask her. So as we prepare for lunch here, I have a couple notes. There is an elevator to get to the lower level here of the auditorium. If any of you feel like you need to use that, please see me, and I can kind of arrange for that for you if you feel like that's a little easier. Again, I know I'm a broken record, but please do consider filling out those registry forms if you haven't done so already, and hand them to me or any of the other volunteers at the conference. We have the remote health monitoring study as well, that yellow form. Certainly see the Lutheran Home Association in the exhibit room for more information about that, or you can talk to me. And again, if you filled out that form already, please provide it. We also have that great personal health care study that ALSCA is doing with me. They are also, ALSCA, A-L-S-K-A, they are also in the exhibit area. And then in general, I'm so glad so many of you went to the exhibit area already. Please continue doing that. Let's keep the good foot traffic going, and certainly that encourages the exhibitors to come back each year too, and they provide such great information and resources to so many of you. So please make sure to continue checking them out throughout the day. So as we break for lunch, note there's a number of outdoor seating areas if you want to enjoy those. We have some outside the front door here. There are some outdoor seating areas if you take a right and then another quick right behind, and there are actually tables with umbrellas there. And then if you want to go down to the first floor, there's a real pretty rotunda down there too. I think there's even a waterfall, if I thought I heard it. It's either waterfall or I heard the heating air conditioning unit. It's one of their two. So, I think it's a waterfall though. So, definitely check that out. I think you'll like that. So, So we have a lot of free stuff to hand out here today. If you've noticed, the exhibitors do. I do as well. If you go up by the registration desk, I put out some additional things. There's a flyer for my book that I published last year, so please take a look at that. As you recall, I did a drawing for 3 of them last year, and I think 4 books in total have been sold, so maybe you can be the 5th one. So, okay? All right. Last thing I wanted to mention, we have some photographers here from the School of Nursing Communications office. I know many of you see the brochure I hand out, and if you notice the pictures are in there, they're kind of the stock pictures and photographs. It'd be great if we could have photographs of people who actually come to the conference and the conference itself. So they're here to take some pictures. Now, if you have to opt out of the pictures for whatever reason, please let me know, and then we'll figure out a way not to include you in a picture. I'm hoping that isn't the case. If any of you want to meet with me, I know many of you wanted to talk with me for various reasons today. If you would like to meet with me and don't mind having the photographer there too, I mean, that would be nice. But that would also just show some other good photos there. And if anyone is willing to just have some pictures with you and your family, as again, some resources and materials I can use to put in the brochures and on the website and everything like that, that would be really, really great, and I'd appreciate it. So please consider. Tom and Chris, they're right back here. So if you see them, and if your family is here, you want to take pictures with them, I'd really appreciate that. Thank you, everybody. Let's break for lunch. It should all be set up out there, and we'll reconvene at 12:45. So 1:45. Thank you.